Hi, my name is Christy Green, and today we're going to talk about sleep disturbances in my geriatric syndrome case study. Geriatric syndrome refers to clinical conditions that often present in the older adult. They do not usually fit any kind of particular disease category, and it's usually one or more symptoms as a result of a health impairment. It involves one or more organs, and it often leads to impaired function, negative quality of life, and disability for the patient. Basically, the presenting symptoms usually does not correlate with the specific pathological condition that is causing the symptoms, and it's often difficult to identify the underlying cause. Risk factors contributing to geriatric syndrome: the older adult, elderly, frail, those that are cognitive and functionally impaired, those with gait instabilities or have a history of falls and need assistive devices for ambulation, those with acute or chronic illnesses, elimination disorders, sensory deficits, alcohol use, and depression. So let's talk about sleep disturbances. Sleep disturbances are not diseases, but they're rather just a group of symptoms that result from underlying problems or conditions. They may be the result of physiological, psychological, or mental imbalances. However, the lack of sleep in return may actually further exacerbate the underlying problem. Sleep patterns do change as we grow older. We have a decreased production of melatonin, and this can be very common in the older adult population. Frequent awakenings and decreased sleep time is usually contributed to old age. However, for this reason, many sleep disturbance problems are missed or underdiagnosed by the primary care providers. So the quantity and quality of sleep for our patients should be included in every geriatric assessment. And those with dementia, depression, delirium, GERD, respiratory problems, anxiety, and pain are those that should be particularly evaluated to ensure that they are actually getting the adequate amount of sleep. There are more than 80 sleep disorders. However, we're just going to talk about a few here today. There are those conditions that would be considered disturbed sleep, such as sleep apnea, which is the blockage of air passages due to the soft tissue collapse in the oropharynx. Rapid eye movement disorder involves abnormal movements, behaviors, emotions while you're sleeping. Basically, the patient will be acting out their dreams or chasing or attacking in their sleep, and this can be often associated with CNS disorders. Sleep movement disorders such as a restless leg, periodic limb movement, sleep leg cramps can be associated with renal failure, inadequate folate or iron, neuropathy, RA, and fibromyalgia. Narcolepsy is the inability to control the sleep-wake cycle. It usually involves uncontrolled episodes of falling asleep regardless of the activity and can be associated with neurological disorders. Insomnia would be considered a lack of sleep, which is difficulty falling asleep or actually staying asleep. And once the person is awake, they have difficulty returning to sleep. So they are fatigued, tired, have trouble getting out of bed, and this leads to a decreased concentration. They have a decline in cognition, physical performance, and are more at risk for falls or respiratory depression. So some research regarding sleep disturbances. In one study, there was 203 older adults aged greater than 75 years old, and medical histories, functional abilities, medications, and the condition of their sleep disturbance were all evaluated. Every person at least had one chronic disease. And as you can see there is in the results that the older adult population experienced several problems with sleeping. 26% of the participants had less than 5 hours of sleep, and 93% woke at least once. So 18% require the use of a sleep aid medication, and usually that medication is benzodiazepine, despite recommendations to avoid its use. And 60% of the participants suffered from insomnia. So this is a very common problem among our older population. So how does this affect nursing? So over the past decade, there has been over 5 million complaints of sleeplessness visits with complaints of sleeplessness to the primary providers. And it is estimated by 2030 that 1 in every 5 Americans will be older than 65. So as a provider, we can expect there will be an increase in the number of sleep disturbances that we will be evaluating. Sleep is essential for our physical and mental health, and it often correlates directly with medical, psychiatric, and polypharmacy in the older adult. So it is imperative that the FNP is aware and capable of recognizing these symptoms. It is not a normal part of aging, and this is why there has been ineffective treatment for sleep disorders. We must recognize the severity of the sleep disorders and that there is an increased risk for medical or psychiatric morbidities, increased risk for mortality, increased risk for falls, and for those elderly adults that are sleep deprived, they are at greater risk for suicide. As a provider, it is our primary goal to improve the quality and quantity of the sleep. So by doing this, we must manage the comorbidities that contribute to the sleep loss, and we must evaluate and review all the medications, including over-the-counter and herbs every night, at every visit, and any medications that we find that may be contributing to the sleep problem should be changed if possible. Some non-pharmacological interventions that the FNP should be aware of may consist of cognitive and behavioral therapies. These are usually more beneficial, and they have long-term benefits, and they are safer as compared to medications. Sleep education, sleep hygiene, stimulus control, sleep restriction, relaxation, and cognitive therapy. However, for pharmacological interventions, once again, like I said, the benzodiazepine is commonly used for sleep aid in the older adult population, despite its recommendation by the American Geriatric Society to avoid. The benefits of this medication will not outweigh the adverse effects of dependence, tolerance, abuse, falls, cognitive impairment, delirium, and ataxia. Non-benzo receptor agonists, your Ambiens, also increase the risk for cognitive impairment and falls, and they usually have minimal sleep improvement. These should be avoided also, and if they must be used, really 90 days is the maximum time. So melatonin, antihistamines, and serotonin antagonist reuptake inhibitors, your trazodone, may be considered on an individual basis. It is essential to treat underlying conditions in order to prevent the use of medications and sleep aid. The patient in this case scenario has a long history of diabetes, hypertension, anemia, GERD, IBS, a lot of arthritic and chronic pain. She has fibromyalgia and gout. So she is on several blood pressure medications, asthma medications, omeprazole for GERD, gabapentin, meloxicam, and she does take a lorazepam every night for sleep. Some risk factors there for sleep disturbances that you may be looking for is obesity, smokers, anxiety, depression, chronic pain, and hypertension, CHF, and diabetics. Those that use alcohol, opiates, sedatives, and those that have endocrine, metabolic, or neurodegenerative disorders, steroid use, or antihypertensives. Some common complaints when you review the symptoms would be difficulty maintaining sleep, fatigue, tiredness, poor concentration, irritability, morning headaches. They may think they are depressed, feel depressed because they are tired and have no energy to do anything. So basically, you need to rule out other disorders before diagnosing the person with sleep disturbance. So patient objective. This patient really did not have a lot of presenting problems or complaints regarding she had no falls. However, she does have arthritis with decreased range of motion to her shoulder, and which could lead to a fall since she is taking her lorazepam every night. So to diagnose, we would, like I said, we need to rule out underlying conditions. So we want to evaluate for thyroid disorders, anemia, iron deficiencies, vitamin D, B deficiencies, glucose, to rule out diabetes. We want to evaluate kidney and liver functions, heart failure, any kind of cancer screenings, and drug screens, and some autoimmune problems such as for rheumatoid or lupus. An actigraphy is a device that measures movements of the arms and legs while you're sleeping, and then of course sleep studies will measure endurance, quality, and for the person sleeping, and we can evaluate for seizure activity. We can use questionnaires, and this is important. This actually has the patient to do a self-assessment on. There's several questionnaires we can have them fill out regarding their habits, their dozing, napping, or time between naps, and then activities that they're doing prior to going to sleep or trying to go to sleep. So ruling out differentials, we need to, like I said, rule out respiratory, heart, metabolic, endocrine, neuro problems. We need to rule out any substance abuse or iron, B12, vitamin D deficiencies before actually making a diagnosis of a sleep disturbance. So diagnosing and treating this patient, she does have a history of chronic anxiety with GERD, hypertension, IBS. She is on blood pressure meds and a benzodiazepine. So after ruling out any underlying conditions, we would diagnose her with insomnia, probably related to her anxiety and her IBS. So we need to make sure that her healthcare providers, cardiologist, gastroenterologist, pain management is effectively treating her arthritic, her heart, and her bowel issues. When those symptoms are controlled, she may be able to sleep better. We need to actually have her stop taking lorazepam. However, long-use lorazepam results in tolerance and dependence, so we want to gradually reduce her off and taper her off this medication, and this could take up to months. While doing this, she could undergo cognitive and behavioral therapies for sleep hygiene. And if we have to use a medication, we could start her on some melatonin or even trazodone, which promotes restorative sleep, and it does have a decreased incidence and potential for abuse. So it's much better than the lorazepam. So in conclusion, caring for the older adult is a complex process, and it requires each visit to be specific and individually tailored for that patient. Geriatric assessment should evaluate medical, social, and environmental factors that influence the patient's health. Not two people of the same age will not present the same, so their health, function, vision, hearing, cognition should all be evaluated. The FNP should have the responsibility not only to address medical concerns, but cognitive function, social, and environmental factors which will affect the person's well-being. Sleep disturbances will always be symptoms of underlying conditions, so ineffective management of a sleep disturbance will further exacerbate the underlying cause, thus furthering deterioration of the patient. So we spend about 1/3 of our life sleeping. So implement sleep assessments into each visit to ensure that this patient is receiving the adequate time and good quality sleep to ensure physical and mental well-being. Thank you for your time.